Welcome, everybody, to Rush University Medical Center Division of Nephrology Renal Biopsy Conference for October 20th, 2022. Today's CME activity code is 486597. We've got a great case today, Dr. Whittier. Welcome, everybody. I see some new people in the crowd, so we're glad to have you. We also have 5 applicants today for the fellowship, and we welcome them. As usual, we have nothing to declare. And as usual, to ensure patient privacy is preserved, identifying information and or other details, including ethnicity, date, gender, etc., laboratory values, have been changed to disguise the identity of the patient and protect patient confidentiality. And with that, I think Dr. Whittier is going to walk us through the protocol. Bill?
Yeah, thanks, Roger. Today we have a 19-year-old Black man without any significant past medical history who presented to the emergency room when I met him with fatigue, bilateral leg swelling, and abdominal pain. So his medical history goes back a little bit in time here, where he first noticed leg swelling and weight gain that was relatively sudden 3 months ago, and he saw his internist. His internist also noted in the that he had a 30-pound weight gain, and he had done an exam and saw these abdominal stria. So he was very concerned that the patient had Cushing's syndrome. So he was actually sent to endocrinology for further evaluation, and he wanted to get a salivary cortisol level. 1 month later, he actually presented to the emergency room with his current symptoms of just increasing swelling either further, and now it was involving abdominal pain, fullness, as well as shortness of breath. So there was some blood work done in his PCP's office 3 months ago or 4 months ago. And his blood work was notable for, at that time, he had a low total protein and a low albumin. He was also hypertensive in his doctor's office at 145/100. He states that, it's been about 40 pounds of weight gain since he first saw him. And most recently had become more abdominal distension as well as a shortness of breath. And that's why he'd come in. So he does take occasional NSAIDs. He uses them about once a week for headaches, and he's done that for the last 2 months, which is when his headaches started. So he doesn't really have any past medical or surgical history. Social history is also insignificant. There's no end-stage renal disease or autoimmune diseases. His medications were only hydrochlorothiazide, which was recently prescribed by his PCP. He was on no herbal medications, and again, the NSAIDs, as I said. On exam, it was really just remarkable for he was hypertensive. His blood pressure was 160/102 when I saw him. His weight was 240 pounds, and about, again, 3 to 4 months ago, he was around 195. He was resting comfortably. He wasn't in acute distress, but he did have some abdominal fullness. He had the stria that were noted by the internist on bilateral flanks, and he had about 3+ edema, which was symmetric, and it was all the way up to his thighs. So outside labs 4 months ago, his creatinine was 0.9, his albumin was 2. They had checked a BNP and a troponin, which were both normal. And then on the emergency room labs, when he was being admitted, his labs were notable for a K of 3.7, his bicarb was 27, his creatinine was 0.9, which was unchanged from a couple months ago. His albumin was now down to 1. His total protein was also low at 4. His corrected calcium was normal, which I didn't include there. His liver enzymes were normal as well. His total cholesterol was almost 600, and triglycerides were 296, and you can see them there. His CBC was unremarkable. His workup for secondary GN was essentially pending because when I saw him, it was a Monday, and we were able to get the biopsy on Tuesday. So his ANA, double-stranded DNA, complements, and PLA2R were all pending. His immunofixation was also pending. The HIV and hepatitis panel, as well as COVID, comes back pretty fast, and that was negative at the time of the biopsy. So his urinalysis shows 4+ protein, 1+ blood, 3 to 5 red cells. His urine PC was 7.4 grams per gram, and his urine albumin to creatinine ratio was 5.4 grams per gram. His echo was normal, and his renal ultrasound was relatively unremarkable. His right kidney was 14, his left kidney was 14 centimeters. He had some minimal ascites, and he also had a right pleural effusion. Somebody may need to mute. I'm not sure if who that may be. There's some background noise. It's not from me. So anyway, when we saw that he was nephrotic like this with nephrotic syndrome, we decided to do the biopsy.
Great. Any questions for Bill? So Bill, this was like a 3-month history, you said, and
Yeah, 3 to 4 month history, and it took a while with this weight gain for him to come to us, but but I knew that we were going to find out something when we got the kidney biopsy. In the chat there, no, I couldn't appreciate any lymphadenopathy on exam, and we didn't have any imaging studies looking at his thorax, and there was no skin rash. There was a stria, but there wasn't really an active rash.
yeah, the stria is interesting.
Bill?
I'm sorry.
Bill?
Go ahead, Dick.
Yep.
What is the current turnaround time for an anti-PLA2R at Rush?
I would say probably 5 to 7 days. Do you guys think that's about right? Yeah.
Yeah.
Unfortunately, similar to ANCA. ANCA may be 3 days.
I think it's sometimes longer, actually.
Yeah. If the turnaround time was 48 hours, would you have biopsied this patient without knowing what the PLA2R was?
Yeah, it's a good question. You know, he was, yeah, I may not have. He doesn't have renal failure. He doesn't have anything that, but he was pretty symptomatic, but I don't think that necessarily waiting 2 more days would have harmed him. He was coming into the hospital anyway for, you know, aggressive diuresis. So we were kind of just wanted to get an answer to the diagnosis and not quite wait, but it is a good point.
And it'll be interesting when that test, if that test ever becomes readily available. I mean, that may be the new algorithm, you know, in the right person, you know, just wait for that. You know, a day or two isn't going to make a huge difference for someone who's this nephrotic. Any other comments?
It's a good point. I think I was in the emergency room with him, and I was seeing how sick he was, and I wanted to get an answer right away. But if he came to my office, you know, I'd be getting the PLA2R, and we'd probably be setting him up for a biopsy in a week or two. If the PLA2R came back positive, I wouldn't be biopsying him. So I think that's a really good point. I would also say that the relative frequency of you know, nephrotic syndrome, if we know that PLA, you know, if it becomes back PLA2R negative, you know, the relative frequency of membranous and minimal change of focal sclerosis and minimal change would go up so much higher that we might be actually turning into the same way that pediatricians do things, where they just treat with prednisone if your PLA2R is negative, because so many or so would be relatively more steroid responsive. So that might be an interesting way that goes in the future as well.
I think Dr. Kark just turned over in his grave, but
well, me too. Believe me.
I think the stria is interesting. I don't know that I've ever seen stria from something like this. I've always think of them as taking a little bit longer to develop, but you know, that's tells you just how much he's stretched his skin, I guess.
Well, maybe it's Cushing.
Yep.
All right. Before we discuss this, I think we have a poll. I want to see what the audience thinks. So we have 5 options here, and everybody can vote. We don't know who says what, so please vote. What do you think this patient has? Lupus podocytopathy, membranous nephropathy, minimal change disease, focal sclerosis, or Cushing's disease? Somebody should put Cushing's disease for fun, I suppose.
Well, the primary thought so.
No, I think it's great. I think it's kind of remarkable. I mean, it's a shame that this does happen. These patients come to us or they go to somewhere else first, and they don't even get a urinalysis, or they can't even tell that the weight gain is edema and not.
Yeah, and labs at the time actually showed hypoalbuminemia. So to me, it was like I would just wish I could have gotten him a little sooner.
Give it a little bit more here.
Nice response rate so far. There we go.
Yeah, very nice. Got a lot of people on today. Thanks for voting, everybody.
It's hidden. We don't know what you voted for, so. All right, I think that's good.
All right, so we've got 3 people said lupus podocytopathy. I think that's not a bad call, really. Even though it wasn't very popular, we don't have his serology back, and you know, it's say what you like about race and association with diseases, but I think it does become relevant when we start predicting what people have, and lupus is more common in blacks. Membranous 8 people, minimal change 17, and focal sclerosis 26. So the winner at 48% was focal sclerosis, and a close second was minimal change at 31%. So since the differential diagnosis is the highest differential diagnosis is between focal segmental glomerular sclerosis and minimal change disease, I only think it would be appropriate that we call on our focal sclerosis and minimal change disease expert, Dr. Corbett, to walk us through his thoughts on this case.
Thank you. Yeah, an interesting case. I mean, for me, this is sudden onset nephrotic syndrome. I know there in the chat there was the issue of a few red cells and whether this is nephritic or not. I think the guy's renal function is quite good. There are a number of nephrotic syndromes or lesions with nephrotic syndromes that can have hematuria that we know. I mean, you can see it in membranous, you can see it in minimal change disease. You can see it in FSGS. It's less frequent in minimal change, but it still can occur. So I think this, at least for me, this is nephrotic syndrome, if we're going to classify it into one of those syndromes. And it's sudden onset, which I think is interesting. For me, that kind of narrows it down fairly quickly to minimal change disease and FSGS. I mean, membranous can do it, but in someone, especially 19 years of age, not that he couldn't have membranous, it would be kind of, I think, on the lower end of the age group for membranous GN. So minimal change, FSGS are my two high ones. I mean, could it be a lupus podocytopathy? I mean, that's a possibility. You know, minimal change was kind of coming right out at me, and you know, the usual, you know, low albumin, high cholesterol. What I found interesting was the cholesterol is almost 600, but the LDL was only 92. Usually the LDL is equally as high, is extremely high as well, but for whatever reason, this person's LDL wasn't too bad. I don't know.
You know what? I'm sorry, that's a typo. It was 292.
Fair enough. I was going to say he might be protected from having cardiovascular disease with whatever he's got. So yeah, I mean, for me, minimal change disease is number one on my list, probably number two and number three. FSGS is in there. You know, you think about the tip lesion, but that's much less frequent in African Americans than it is in Caucasians, but it's still possible. Collapsing FSGS is a possibility, but I would have expected his creatinine to be higher. He is hypertensive, which goes along with FSGS in general. I mean, those are my top two. Membranous is kind of a distant third. You know, then you can get into a litany of other unusual things, which I'm not going to list because I just don't think that they're that high up into the list to make it part of the differential. So I'm going to stop and give room for someone else to weigh in. But I think this is most consistent with minimal change disease. I'm amazed that Bill didn't start him on prednisone right away, but that's just
like you would, right?
I may have.
Just
oh,
like
you may have.
I've never said whether I did or didn't.
Okay, you don't get defensive.
From the king of defensiveness.
I guess the question is, would you have started him on steroids yourself? Is that what you're saying? You'd start 60 prednisone before the biopsy?
Yeah.
And before a PLA2R is back?
Yep. The other thing with the stretch marks, I mean, I've seen plenty of obese patients that don't have cushions that have stretch marks. I mean, we see them in patients with nephrotic syndrome usually after they're on steroids, and that's kind of one of the side effects that we see. But you can see stretch marks in obese patients just in general.
So, Casey, what do you think's going on here, Dr. Gashty?
Yeah, I do agree with Steve. I think the classic triad of sort of the FSGS, minimal change, membranous, but the order, I think, because of the sudden onset, the young age, and the cholesterol level, I think I would lean more towards the minimal change disease. We've talked about the albumin, selective albuminuria, the albumin to protein ratio in the urine being here, I think it's, I don't know, 75%, 80%. So it's a little higher than what it is in the blood. So this to me sounds like minimal change disease.
Yeah, that's a good point. I always look at it the other way. I don't really look at the that way. We've talked about it many times, but that's a good point. By the way, are you Is this your new Barry White voice that we are hearing?
Laryngitis.
Oh, okay. I don't know if 10% of the audience knows who Barry White is, but if only one of you gets it, it's worth it. Dr. Glassick, I'm sure you know who Barry White is, and I'm sure you have an opinion on the case.
Well, I'm surprised nobody made a comment about kidney size. I don't know the patient's height, but 14 and 13.6 seem on the higher end of normal, which would certainly be more likely due to minimal change disease than FSGS. And I would just reiterate the issue about albuminuria as a fraction of total protein excretion, which is about 70% in this case, which is a little low for pure minimal change disease. So we have large kidneys pointing towards minimal change disease and a relatively low fractional excretion of albumin relative to total protein pointing in the direction of FSGS. I would have difficulty making a pre-biopsy firm diagnosis of minimal change disease, although it's certainly the leading candidate.
Would you treat this patient with steroids before a biopsy?
What?
Would you treat this patient with steroids before, while you're waiting?
No, I would not.
So your point is that it's not high enough albumin or low enough. Well, the albumin ratio to protein ratio should be much higher. I think Casey's point was it's higher than we're used to seeing. We're seeing 50 to 60%. This is closer to 75, but you're saying it should be, you'd like to see 80 or 90%. And it's an interesting, one or the other, but I think it's a good point and something that I haven't really been appreciating in the differential diagnosis, probably because we haven't had these always available. Getting a urine albumin creatinine ratio with a protein creatinine ratio, we used to do under only certain special circumstances, but for whatever reason now it's become pretty much habit. The first time we check a protein creatinine ratio, we'll get an albumin creatinine ratio with it to kind of get an idea. More on the other side to see if it's very low. I mean, it wouldn't be really apply here, but see if the albumin to creatinine ratio is a small percent of the protein creatinine ratio, indicating either tubular interstitial disease or overflow proteinuria. Anybody else have any other opinions? Anything else in the? Okay.
The only thing I was going to say is, I don't know if someone mentioned this is the blood pressure. I put it in the chat. I don't know if the blood pressure sways anyone away from minimal change disease at all. I mean, it's pretty high. Kind of points to me a little more FSGS rather than minimal change disease, because he wasn't hypertensive before, and this started happening along with his weight gain and nephrotic syndrome.
I think that's a good point. Actually, in the chat, someone says overfill rather than underfill. And, it might go along with the blood pressure. It might go along with the shortness of breath as well. If you think of minimal change as the really only underfill. But then again, the reason minimal change has been found to be an underfill, in other words, intravascular volume depletion, is because it's so acute and it's so severe. And, that's maybe not that different here, although this is over 3 months and not over, 3 or 2 weeks, which is often what we see with minimal change disease. So let's see who reads it. I'm going to spin the wheel.
The wheel was ready today.
Yes, the wheel didn't time out. It got impatient last week. It timed out on us. I talked to the wheel and it did apologize. Well, we might as well keep it up. Dr. Corbett. Dr. Corbett's one of our fifth-year fellows.
Feels like it sometimes.
Go ahead, click on the screen, and you'll be able to advance the slide. Go ahead. At the bottom left, yep.
So we have a trichrome here. Looks like we got some muscle. Is that David?
Yeah, that's muscle.
What's this? Is this
Connective tissue.
Oh, okay.
It's,
Yeah.
it's periosteum of the rib.
Yeah. Okay. A little bit of everything here. If he's got myositis, we'll be able to make that diagnosis too. So on the trichrome, I don't know, it looks about, it's definitely blue staining material. Well, these are gloms. So this is cortex. It looks like this is almost all cortex, right, David?
Yeah.
So I don't know, 25%.
Yep.
Fibrosis.
Yep.
We'll go to there's a PAS, and we've got 1, 2, 3 gloms that at least at this power look pretty good. They fill up Bowman's space. I don't see any segmental scars or any proliferative activity, at least in these. We have a blood vessel here, I believe. And you can see the proximal tubules have good brush borders. Again, this is kind of a low power, but I think it's pretty apparent that you can see the brush borders. And the guy's creatinine is actually quite normal anyway, so I wouldn't expect any ATN at this point. Or even though it might.
Yeah, so actually the trichrome was a little misleading because there are no atrophic tubules, are really areas of fibrosis. So I think that was just areas of understaining.
Interesting.
Yeah.
I've never heard that before, but
Yeah.
I don't know why oh, there it is. Is this the next one, David?
Yeah.
Okay. So a little bit higher power. Again, the glomerulus looks normal to me. The mesangium looks normal. Capillary walls, at least on this PAS, don't look all that thick or rigid, which we always talk about with membranous. Again, the brush borders look excellent. Aha. So one normal looking glomerulus, one with a segmental scar. And this looks like a peripheral scar. I would think, well, it's hard to know on this one where the hilum is, but for sure we see a segmental scar, and it doesn't look proliferative. There doesn't look like there's any necrosis or any proliferation. This all looks pretty scarred at this point, and it almost, and I believe an adhesion to Bowman's capsule.
Yeah, but I can make out some of the orientation of the glom. I mean, what's
Well,
that?
I'm trying to
right
figure,
up
is this the
at-
vascular pole here?
Yeah.
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 So it's a peripheral lesion. I don't know that I could, they used to talk about peripheral lesions as well, versus hilar lesions or perihilar lesions. I mean, the real issue of whether this is a tip lesion or not, I think is going to depend upon whether we find it coming at the takeoff of the proximal tubule.
Yeah,
I
because
guess
you
it
could
could
see
be it right here.
yeah,
looks
so
like
just
it
you
may
could
be
follow
there.
that right into the lumen of the glomerulus.
I think that is.
Well, this is
Yeah.
where I would expect it to be. I don't see brush border here, but I mean, that's definitely one of the things we're going to think about is that this is a tip lesion versus just a lesion away from the hilum. I'm blocking the name. I'm blocking the name now. But I mean, do you see the proximal tubule, David?
Yeah. I mean, that's the lumen of it. Where you're
Right here?
Yeah.
Okay, I'm just curious why there's no brush border.
Well, yeah, I don't know. It's kind of thinned out. The epithelium's
I
kind
mean,
of thinned
you
out.
expect brush border even in the proximal tubule, right?
Yeah.
I mean, this looks like a distal tubule to me. Anyway.
No, that one to the right was another proximal.
This
I
one?
see. Yeah, that's proximal.
Okay.
It has a little brush
Like I say, I
border.
don't, maybe the brush border is just kind of gone.
Yeah, you don't see brush border very well anywhere. So
Yeah.
I think I know your point, Steve, but I don't
I
really.
mean, I can
it's
see
not-
it here. I can see it here.
yeah,
Fair enough.
Maybe. Yeah.
Here we have a silver stain, which I don't see any spikes. I mean, you can have segmental scars in membranous too, so it doesn't mean that membranous is ruled out. I don't see spikes or splits, and this actually looks quite normal to me.
We sometimes talk about the protein reabsorption droplets, and you can
Yeah,
see them on that
I didn't-
on the
I
silver
didn't s-
there.
I mean, there are a few maybe. Here's a few here.
Yeah, a few
But
maybe.
I mean, it's not for somebody to have that much proteinuria. They don't seem like there's a lot, but yeah, there definitely are some. And on the PAS, sometimes you'll see it too. And I didn't really see it standing out that prominently. So I'd already hit this. So the IgG is completely negative. So that kind of takes membranous out of the box.
So let me just reiterate about that protein reabsorption. I mean, his proteinuria is not that high, yet his albumin's super low. So, one of the explanations is they're filtering a lot, but he's reabsorbing a lot.
That's right.
And it's not really supported for whatever it's worth, at least by seeing a lot of protein reabsorption droplets.
Here's the electron microscopy. Huh. All right. This looks like fenestrated endothelium to me.
Yep.
Basement membrane, podocyte. But what are all the, but the red cells are out in the Bowman space. Is this, at least these look like red cells to me. Is that what they
Yeah.
are?
Yeah,
So he has
looks like it.
microscopic, pardon?
Yeah.
David?
Yeah, it looks like there's red cells in Bowman space.
Yeah, I mean, you expect to see them here within the capillary lumen, but we knew you had some microscopic hematuria. And one thing that stands out here is one, there's no electron dense deposits, which we really wouldn't expect. And he's got diffuse effacement of the podocytes. His basement membranes are of normal thickness. Here's another one, Bowman space, capillary lumen, fenestrated endothelium, basement membrane, and just diffuse effacement. So he's got FSGS, and I guess we're going to say he has the tip lesion because that appeared to be at the takeoff of the proximal tubule. And we'll assume it's primary, that he has no other evidence of any secondary issues like NSAIDs or lymphoproliferative disorder. He's not on he's not on anything else that I think would cause nephrotic syndrome or even FSGS. I assume all that workup, HIV and all the rest of the stuff came back negative. I mean, there was no evidence of tuberoreticular structures or anything of that nature. So I think this is going to be kind of primary FSGS, if you will, with the tip lesion.
So how does that fit into your original differential?
Well, it's similar to minimal change. Of all the FSGS lesions, it acts more like minimal change than the others do because it's highly steroid responsive.
I guess what I meant was, what was your final call? Did you have a final call?
I said minimal change initially.
Oh,
That
you
was
did, okay.
my, and then I said FSGS is a second.
Okay.
And as I said a distant second, but I did second and brought up the tip lesion as well as collapsing, which he definitely doesn't have collapsing.
Okay.
So it was in there, but my number one honestly was minimal change.
Before we discuss treatment, we have another quick poll here. So what would you do next? We have 5 options. Would you do genetic testing? Would you do plasmapheresis? Would you do CNIs? Would you do steroids? Or would you do rituximab? While you're voting, Dr. Zeng in the chat box made a good point. He said if the one glom that we saw we didn't find it with the segmental scar, we'd be calling this minimal change disease. And that's a really good point.
That gets
David,
into the
how
whole
many-
issue of sampling.
Yeah, David, how many gloms did we have?
15 total.
Yeah. So we won't go into the math, but 15 is a pretty good sample. It all depends on what percent of the glomerula have a segmental lesion that will pick it up. Wait a couple more seconds here. Anybody else voting? Okay, you can close it.
Remind me, Bill, was there any family history of renal disease?
None.
Okay.
People should be able to see the
Yeah. So we've got 20% genetic testing. Nobody wanted a pheresis patient. We have 1 CNI. We've got the vast majority want to start steroids, and 1 person opted for rituximab. So.
And I don't know his birth weight.
Well, I mean, it's interesting that, the issue of genetic testing in somebody like this without a family history gets into the realm, unless you're just looking for APOL1, gets into the realm of how often do spontaneous mutations occur. especially in Potosin, which is where they talk about it the most. In children, it's up to 30%. In adults, it's much less frequent.
Well, I think the bigger question is, would you even suspect a genetic form of FSGS to be this nephrotic?
All the ones, well, like I say, children could present without a family history and have severe nephrotic syndrome and can have, and when they do genetic testing, 20–30% of them can have spontaneous mutations in Potosin.
Okay.
And the only reason that becomes helpful is they're going to be less likely to be steroid responsive. In fact, they're usually steroid resistant.
So would you apply that to a 19-year-old?
Yeah, that's interesting. I mean, he's on the cusp, right? So it would, I would think that it might be reasonable.
Interesting. Well, Steve, tell us what would you do next? Why don't you go through each of these for us and tell us the pros and cons of if they're ridiculous or if they're not ridiculous.
So I would definitely start with steroids. The real issue with genetic testing is the patients with FSGS that are steroid resistant. And it's in that group really where you find the Potosin mutations in patients that are spontaneous and patients that don't have a family history. So if he was steroid resistant, then I think the genetic testing would be interesting to just see if that might account for why he didn't respond. I think plasmapheresis, there is no role for it in patients with primary FSGS, unlike the patients that have relapsing FSGS after a transplant. And even in transplant patients, once they have recurrence of their FSGS, if you don't freeze them within the first few weeks, pheresis doesn't become all that beneficial thereafter. So it makes it interesting, and at least for me, it's always been interesting that whatever this circulating factor is, when it recurs in a transplant, which we pick up usually fairly quickly, if you treat them quickly or early on with a pheresis, you can actually attain a remission. But if you wait too late, there may be other mechanisms that are coming into play that lead to persistent nephrotic syndrome or proteinuria in those patients, and pheresis is not all that beneficial. Calcineurin inhibitors and rituximab as first-line therapy, I think in patients where you might have a concern about giving them steroids to begin with, you could use those as steroid-sparing agents. But I generally reserve calcineurin inhibitors for patients that are steroid resistant or who might be steroid dependent. That'd be one use. Rituximab, same thing. As initial therapy, unlike minimal change disease or membranous, I guess rituximab, I don't know that there's as much information on that. But for sure, in steroid sensitive patients who are steroid dependent or relapsing frequently, rituximab would be a great second choice. Cyclophosphamide would be another one in patients that are steroid dependent or frequently relapsing. But again, in somebody that you were worried about giving steroids to in the first place, rituximab or calcineurin inhibitors would be an option. But I still think steroids would be the first line therapy, and his ability to respond to that will define his overall course.
Let me ask you this. His BMI is 36, and there's a lot in the chat about the possibility, what's going to happen to his BMI on steroids.
Again, I would still give a trial for a month or so of steroids at 60 to 80 milligrams and just watch him closely. A big issue is watching whether or not he becomes diabetic. I mean, that's the real question, is whether he becomes glucose intolerant on the prednisone. And at that point, you might have to back off and try something else. But I've used steroids in obese patients. They can tolerate it quite well sometimes. The issue is how long you have to give them. If he doesn't respond, then you get yourself into a bind of whether you want to keep someone like this on long-term steroids, because then you do get into problems.
Yeah, I don't think it's such a bad idea, though. I mean, if this guy's really big, you could put him on a CNI, get his proteinuria down, and give him rituximab. I mean, that's based on the assumption that he's steroid responsive, which you don't know. But I don't think it's an unreasonable approach.
I didn't say it was unreasonable. I'm just saying that's what I would do.
No, I know that. I'm just playing devil's advocate here and commenting to the chat board. I think it's, that's not a crazy idea in my mind. If someone's quite big and you're really worried about steroids, or they've had a history of, specific steroid problems, bone disease, psychosis, whatever,
well, I mean, if you're going to take that route, I mean, the only reason CNIs might be better is because that's what kind of the first line is in patients that are steroid resistant. So in a way, you can kind of cover both bases. The other issue would be,
I'm just buying time. I'm just buying time until rituximab can work, is what I'm trying to do. It's just a we don't need to talk about it more. I'm just,
Got
I
it.
just, I think
Got
that clearly D is what, most people feel, and it's for the right reason, because that's what we always use. But I think, it's always interesting to try to think out of the box, and maybe there are situations, rituximab is not used for primary treatment, but I suspect if someone's steroid responsive, you could give them rituximab, it would work. It just wouldn't work as quickly, and you'd have to deal with less steroid side effects, but maybe more nephrotic syndrome side effects, because you'd have delayed response.
Well, you bring up an interesting point, and that is how fast do CNIs work relative to rituximab?
Well, I thought my impression of CNIs is it's working directly on the podocyte, so you have a pretty rapid decrease in, doesn't fix the problem per se, but has a pretty rapid response. We'll use it sometimes in membranous when we don't want to wait for the for our membranous protocol to kick in and the like. I don't know, probably overdoing it, the whole discussion part of that.
Yeah. Let me, before you leave this point, I want to entertain a little small discussion about the role of the Columbia classification in making therapeutic decisions. As you know, quite a few very reputable pathologists, renal pathologists, no longer even report the Columbia classification in the biopsy report. Helmut Renke hasn't used it for years. Sanjeev Sethi says he's not interested in communicating any information about the Columbia classification because he finds it not useful. What is the current position at Rush? Do you pay any attention to the Columbia classification or not?
I still do, but I don't, it's not like I put everything, all my eggs in that basket. It gives me a sense of what I think might happen.
But you among all the people on this call have emphasized that it's not the lesion that makes the difference, it's a response to steroids.
No, that's exactly right. And I stand by that. I mean, that's, as you well know, that was Renee Habib's editorial in KI, it was like 1973 or something. And that I think that point stands, still stands today. And I've always given her credit for that. I think that's exactly right. The responsiveness to steroids will define the prognosis. I think the classification, which I'm sure, it has its downfall, just like making the diagnosis of FSGS. I mean, if you don't get a good sample, you could, as was already brought up, you'll miss the lesion and you'll miss the diagnosis. But for me, it just gives me a sense of what I think might be the response to steroids. But by all means, the ultimate answer is what actually the response is. I mean, even Howie showed that there are patients that have the tip lesion. If they have coexisting segmental scars that aren't, they don't have collapsing FS, but actually have other segmental scars, those patients don't act like the patients he originally described with the tip lesion. So not all people with the tip lesion have that great prognosis. So I agree with you. I still think the response to therapy is key, but the general classification I find just kind of helpful in trying to explain to the patients what I expect.
I find it completely unhelpful.
I assume that.
I frankly pay no attention to it, and I'm perfectly happy in making a decision about treatment in a patient with an FSGS lesion without any reference to the Columbia classification.
So you're making it totally on the clinical presentation then?
Yes. Renal function, degree of hypoalbuminemia, the lesion itself, and the contraindications to steroids. That's a clinical determination, and diabetes and psychological disturbances, unwillingness to take the drug because compliance is a big factor, is the decision-making, not what the lesion looks like under the Columbia classification. And I think, Steve, that's probably about where you are too.
No, I mean, ultimately, as I said, it doesn't, it's not like I'm not going to treat somebody with collapsing FSGS. I mean, we actually showed years ago, those patients can respond quite well if the lesions aren't widespread. Yes. Exactly. The response to treatment for me is the final denominator.
Well, it is interesting. We've talked about even the possibility of even empiric treatment here. So it would be amazing if someday the algorithm for this patient, and it'd be a lot easier if he was, if we convinced he didn't have a high BMI, but the algorithm for this patient could be PLA2R, then if negative, very nephrotic, give him steroids and see what happens. I don't know. It's hard to envision that day, but we've changed a lot over the last couple decades, and that may be possible. Maybe maybe we'll find a marker for FSGS. Maybe we're starting to find one like nephrin, anti-nephrin antibodies for minimal change, which is hardly, we're not, that's not a complete story yet, but
The problem with FSGS is just as kind of being alluded to here. I mean, it's a lesion, which Helmut always says. In fact, what was it? 2 Sundays ago, I kind of got in for a little while on the discussion, and I know Dr. Glassick had some comments, and I know Helmut definitely had some comments. And the issue is it's a lesion. It doesn't tell you anything about the pathogenesis or anything else. And so until we find out more about the mechanisms that cause this disorder, if you will, or this lesion, it's not a very specific thing. It's just a
pattern of injury,
that's right, a pattern of injury.
All right, Bill.
Tell
us about the pattern of injury.
Thank you. I mean, I think this is kind of really this discussion that Dick brought up and we continued really is what I want to talk about today, because this response to steroids has been an amazing way to sort of tease out some things, but it's also been a little bit of a problem because if your only determination is a response to steroids for your long-term outcome, then that means everyone with FSGS is going to get treated with steroids. And so as great as that is, that some will respond, it's also terrible because we see as clinically practicing nephrologists, I can't tell you how many times we've had second opinions where a person with clearly secondary FSGS or some other undetermined FSGS has been called primary FSGS. They don't have nephrotic syndrome, they don't have foot process effacement, and they've been through prednisone and cyclosporin and all these things that really just were not indicated. And that's kind of what I want to focus on here is I want to just take us through a little bit of the history from this evolution of FSGS. Once it was considered to be a completely untreatable disease, and let's just put a fistula in the person and get them ready for dialysis or transplant. And now it's really morphed away from the Columbia classification into a pattern of injury. So I'm just so glad that you guys already sort of led into this. And this is really where it all began in the 1970s and or early 1970s. Every time cohort series were done, even with low-dose prednisone, the response to low-dose prednisone was dismal. Klein-Bolton, Cameron, all these reports were done in the 1970s that basically said low-dose steroids gave you about a 20% remission rate for complete remission. And here's some other ones that just said the same thing. There's an untreatable disease and we really don't have the best outcomes with it. And so nephrologists at that time were appropriately reluctant to treat somebody with steroids and give them all the attendant problems that you can get with steroids and not have any benefit. But then, there were a couple of things that needed to be teased out. Was it possible that it was the dose of steroids? Was it possible that the way it was given? And so then in the 1980s, higher dose steroids, prolonged steroids, several cohort series came out and showed that the remission rate was improved. And here's some of these studies here with Chan and Pei and Dan Catran, of course, and Agrawal. And Rush was a big part of that story too. It went from this untreatable disease to maybe it is treatable, and to we really think that it is treatable, and up to 50% or even 60% in some series had that it was a treatable disease. And so this was a lot of Mel Schwartz and Ed Lewis and Steve Corbett, of course, were huge and instrumental in changing this disease from one that was really a death sentence to one that was now treatable. So pretty amazing along the way that they were to help these patients and not just keep them off dialysis, but keep them alive with finding out the appropriate steroid dose and what we could do with it. And then once we knew that it was steroid responsive, or some of them won, let's try to sort out and tease out who we need to treat. And so that's kind of the next a decade or so, where patients were being reported on, response to steroidness and response to steroid therapy. And was there anything in their histologic or clinical presentation which can lead one to think that they're more likely to remit. And this was done with a lot of glomerular diseases at the time. I mean, membranous comes up in the pre-PLA2R era, and who are you going to treat? You know, if some patients are going to have spontaneous remission and they only have a gram of proteinuria or something, then you may just keep them on an ACE or an ARB and watch them. And so we really tried to tease out over the years of this decade of which ones were the right patients to treat. And it kind of was then based on the features that were associated with a poor prognosis versus those that were associated with an improved prognosis. And so here's a nice table about showing you the clinical features that are associated with a poor prognosis, and then some of the histological features. And I wanted to just mention this a little bit more, and that the response to steroids really defined whether you were going to have a good long-term prognosis. And as great as that was, I think it was also penal. As great as that was to help patients, it meant that every single nephrologist that's practicing decided that anyone with a label of FSGS on biopsy was going to get steroids. And that, of course, it was a huge problem. And I think that the Columbia classification kind of lent to that problem a little bit more, because you could, of course, have patients with the cellular lesion that you see there depicted below in this slide that they might respond. Or you may have a tip lesion that was supposed to be classically responsive that wouldn't respond. And so what it made everybody think was, oh, we have to treat all FSGSs. And soon you may have a secondary FSGS or hyperfiltration injury, or you may have a genetic FSGS that you really shouldn't give steroids to. And so as helpful as it was to get somebody started on steroids and actually treat, I think it was great because we rescued so many patients, but at the same time, it led to this over-steroid population. And so then, of course, this is what Dick was talking about. This was if you haven't read this article, this review article by Dick and Seth the Infravenza from 2014 or 2015, it is a great, great read, because what it really is saying is, who should we be treating? And there's a classic patient with primary FSGS that should be treated with steroids. And this table, I think, says it the best. If you have FSGS, and again, this excluded collapsing, but if you have an FSGS lesion on biopsy, that doesn't really tell you that there's a disease of primary FSGS. It just tells you that there's this pattern of injury of which multiple factors are there. If the patient presents with diffuse foot process effacement, they present with nephrosis, and they have diffuse foot process effacement, it's pretty easy to put them into that category of primary FSGS and make sure you get that patient on some immunosuppression, most often steroids, as I did in this case, which we'll talk about. If they don't have foot process effacement and they're not presenting as nephrotic syndrome, then it's much more likely that there's some sort of other non-primary FSGS variant, whether it's genetic or undetermined or secondary. Now, this is great for those classic ones, and the majority of them will be classic. However, there's always some questions out there. So you may have somebody who has 6 grams but preferred foot processes. They may have a little edema, but their albumin's not that low. So it gets a little tricky. The majority of the time, you can tease this out. And in our case, of course, we had pretty massive nephrosis, very elevated cholesterol, a ton of edema. The patient did not have Cushing's, and he had foot process effacement with a tip lesion. So he had classic primary FSGS. Okay, and the reason I'm making this point, and I've kept this slide up there, is not just because Dr. Glassick's in the audience, but really the reason I'm putting it up there is because we just have so many times where we're seeing these patients with secondary FSGS that have been exposed to cyclosporin for years, or drugs for years, it was never really indicated. And I think using this type of figure to try to help you sort out who to treat is much more helpful than using the Columbia classification. And so now KDIGO, of course, has picked up on this. And I think this is a much more helpful classification to really determine who we are going to treat. We have our primary FSGS that we described. And in this case, I think should hammer home in your minds the exact presentation of a primary FSGS. Acutely nephrotic, foot process effacement, segmental scar, happens to be at the tip lesion, beautiful. Give them steroids. That's what we're going to do. But in some of the trickier ones, we want to make sure that if they don't have that presentation or they don't have foot process effacement, we've really evaluated them for a secondary or a genetic cause. And sometimes despite them being so tricky, we can't find out what that cause is. Maybe their genetic screen is negative. Maybe they're not obese. They don't have some sort of viral COVID infection that set everything off. And those are really what should be labeled as this undetermined significance or undetermined cause. It's not quite sure what to do with the undetermined cause, but most of those patients do not seem to respond to immunosuppressive therapy. Okay, so what do we do in my case, or our case here? Well, like I said, it was primary FSGS. He happened to have the tip lesion, but even if he had some sort of perihilar scar and he had this presentation and he had foot process effacement, I would still call him a primary FSGS, showing there that the classification of Columbia may not be as helpful. And he had classic, what I pay more attention to on the biopsy is not where the scar is or what the scar is I can't wait to get that EM back. Okay, I really want to see, and someone who presents with nephrosis, I really want to see that they have diffuse foot process effacement. And if that's the case, I think first line is steroids. And this patient, within 3 weeks, had complete resolution of his proteinuria, and his albumin went up dramatically to 60 milligrams of prednisone. He lost so much weight because as soon as his foot processes became intact with the steroids, he just started to diurese like crazy. And I had to get him off. He's one of those patients who acted exactly like a minimal change, where you have to back off on diuretics rapidly because they're going to get so volume depleted. And to this day, and these dates are changed, so this wasn't his exact dates or anything, but to this day, several years out, he has not had a recurrence. So we continued his high-dose prednisone for about, I think it was 8 weeks after his response, and then I slowly tapered it over the next 4 months. He fortunately, even though he had a high BMI, did not have any steroid-related side effects. He was able to lose all the weight of the edema, and then he's right now maintaining about 205 pounds. And remember, before it all started, he was 195, and he'd gone up to about 240. So he lost out his edema, and he gained a little weight out of it, but he doesn't have any proteinuria, and his blood pressure has normalized.
Dr. Corbett, I'll probably get the figures wrong, but about half of minimal change disease patients will relapse in the first year. Does that also apply to focal sclerosis that acts like minimal change?
I mean, they do have a higher, they will relapse. There's no question about it.
In other words, they seem just like minimal change disease. They respond like minimal change. Do they also relapse like minimal change disease?
And they can be steroid dependent.
Yeah. And you would treat them just, if a relapsing, you would treat them just like a relapsing minimal change with
exactly
cyclophosphamide or rituximab or something like that. Yeah.
And everything we've written about this basically alludes to that. I mean,
that's really remarkable how similar they appear, and yet, like Bill pointed out 40 years ago, this was a dim prognosis disease. I wonder, we've all seen patients for second opinions for segmental sclerosis didn't respond to medication that we probably wouldn't, a lot of us wouldn't have treated in the first place because they're either not nephrotic enough or something else, and maybe genetic studies might sway us from doing that. Steve, you probably see a lot of second opinions for focal sclerosis. How many of those, what percent of those do you think you never would have treated in the first place?
Most of the ones I see are nephrotics that had poor response, but there have definitely been patients that were non-nephrotic that I would have never treated to begin with immunosuppressive agents. And I think, I don't know if Bill or who brought this up initially, but I think it's a good point to make, and that is and I put this in the chat, we usually direct the treatment with immunosuppressive agents to nephrotics, patients with nephrotic range proteinuria or nephrotic syndrome that have FSGS, not non-nephrotics. Those patients generally do quite well, and many of them will respond to ACE inhibitors or ARBs. Some of them can go on to become nephrotic, which becomes a different issue. But there are a small group of the ones that I see for secondary have had non-nephrotic proteinuria that I wouldn't have treated with steroids, and we get them off of them. The other caveat is that you don't treat these patients indefinitely with prednisone. I mean, we'll give it for up to 3 to 4 months in adults even in minimal change disease, and if they haven't responded by 3 to 4 months, and you don't have to necessarily be in a remission, but there should be some improvement in proteinuria. Then you want to start getting them off. You don't want to keep them on. And I've had other patients that I've seen, and I'm sure Dr. Glassick has too, in second opinion, who have been on steroids for months and months and months and should have come off a long time before because they just didn't respond and weren't going to. And I think even Dan Catran in one of his papers made the point that if they haven't responded by, 3 months and for sure by 6 months, stop them. And I think a lot of times in the community, they feel that they need to keep them on the steroids with some hope that somewhere out there they're going to get better. And the problem there is the risk of a complication far outweighs the benefit by that point. And then it's time to move on to the next therapy in a steroid non-responsive patient who's nephrotic with FSGS.
What's your algorithm for those patients, Steve? I mean, is it
So the second,
order?
I still use calcineurin inhibitors for the non-responsive patients.
And after
Most
that,
patients with, rituximab has been used. It hasn't been, a lot of these therapies have been beneficial in responsive patients. So in somebody steroid responsive, you use cyclophosphamide, MMF, rituximab, calcineurin inhibitors. In the non-responsive patients, cyclosporin is the drug I still go to. In the lupus, in the FSGS NIH study, MMF and cyclosporin were essentially the same. So it wasn't like MMF was better. For sure, I wouldn't give cyclophosphamide to a steroid non-responsive patient. And even in the pediatric population, they basically suggest against giving cyclophosphamide in those patients who are steroid non-responsive. So I feel the same way in adults. I think the risk of a complication is worse than any potential benefit.
Dr. Glassick, so what is your algorithm for steroid non-responsive focal sclerosis? Steroids and then CNI, and because in the text box, people asking about rituximab or even Athcar, and how far would you go, Dick?
Well, you don't have to wait 16 weeks to define steroid resistance, first of all. I refer you to a very nice paper by the Netherlands group that 8 weeks, if you don't have a 20% or greater drop in proteinuria, you can define the patient as steroid unresponsive, because further treatment is not going to do any good. You have to change to a different approach. For steroid unresponsive FSGS, irregardless of the Columbia classification, I recommend cyclosporin. Tacrolimus can be used as an alternate agent, but the data is based in cyclosporin. Now, if you have a woman who says, I don't want to get hairy, use tacrolimus. And if you have an obese, potentially diabetic patient, don't use tacrolimus, use cyclosporin. But basically, a CNI is the next treatment. Not rituximab, not MMF, not cyclophosphamide, definitely not Acthar gel, and use an adequate dose for an adequate duration of treatment, which is probably around 4 months minimum. And if you don't see a response, stop the drug. If you do see a response, then continue it for at least a year. All of that recommendation is embodied in the 2021 KDIGO FSGS guidelines.
Yep, a lot of that was based on Alan Merrier's data that he had back in, what was it, in the 1980s.
Right.
Because if you taper them off too soon, they'll relapse. And if they make it to 1 year, then you've got a good chance of being able to taper them off.
Right.
We kind of glazed over plasmapheresis and the whole concept of the circulating factor, which I think we should probably spend some time in one of these biopsy conferences, discuss the history of the whatever circulating factor it is. But there are situations where you may want a pheresis, or even lipopheresis has been even a little bit more effective. But I don't know if that would be a primary care. I don't know if anybody would throw their arms up as a last ditch effort, Dick.
Roger, that's for steroid and calcineurin resistant patients.
Okay, so
a steroid resistant patient per se is not a candidate for plasma exchange until you have tried CNI in adequate dose for an adequate duration, unless there's some contraindication to a CNI.
Mm-hmm.
And there aren't very many other than, kidney failure. So
would you think about pheresis in someone who is on tolerating good doses of cyclosporin for a year and not having, or whatever adequate period time, that's still very nephrotic? Would you consider that?
Yes.
Good. That's kind of
That's
what
that's calcineurin resistant disease.
exactly. That's kind of what I was getting at, going down the line to see where, but you would not use
Yeah.
rituximab, cyclophosphamide, or Athcar gel.
In a steroid and calcineurin resistant patient, no.
Okay. Interesting.
But I don't
Okay.
know what the others feel about it. I mean,
No, I mean, I don't know. We're all flying by the seat of our pants to a degree. I just didn't want to
How
throw.
often does pheresis even work in those patients, though? The ones that are resistant to steroids and calcineurin inhibitors? I mean, I don't even know what you're treating at that point.
not very often, Steve, but the exceptional case, sort of proves the rule. And I have seen patients become plasma exchange dependent and very responsive after a long history of steroid and cyclosporin resistance. But you're right, it's not very common.
All right.
I have to leave for another call.
No problem. Thanks, Dick.
Sorry.
No. I'm going to wrap this up unless anybody has anything else. I mean, this is really a great case of pathology and clinical decision making. And I don't know if we know the complete answer, except the one thing that everyone certainly agrees on is that steroid responsiveness is the most important thing. Unfortunately, this patient was extremely steroid responsive, acted just like minimal change, in spite of the fact that it was delayed for a few months before he got treated. I don't know if that plays a role, but I think it does in transplants. If they have recurrent disease and you delay treatment, it decreases their response rate. Steve, you can shake your head if I'm right.
No, that was the whole issue about, especially with pheresis.
Yeah.
I mean, in fact, in a recurrent transplant patients, not to belabor this whole thing, you do a biopsy on them, it looks like minimal change disease. It's early on, and we've published that. It's not until later on that they start developing the segmental proliferative lesions, or the early lesion, if you will, and then ultimately a scar. By the time that's happened, oftentimes they're no longer plasmapheresis responsive. So you really have to pick them up early.
Yeah. So we've kind of gone full circle with a disease that we thought was abysmal to, recognizing the right patient, giving treatment, and actually making a huge difference. And so great job, Bill. Thanks for walking us through this case and doing the background for it. And thanks for everyone else's comments. I'm sure we missed some of the things in the chat, and we apologize, but it was really helpful. And thanks. We will be back next week for another case. Till then, everybody stay safe.